All right, let's talk about a situation you see every single day. A patient walks up to your counter, they've got a cough, a runny nose, and they just feel awful. It's a story you've heard 1,000 times, right? But the real question is, what's actually going on?
Is it just a common cold? Is it the flu? Could it be COVID? Or maybe it's just their seasonal allergies kicking in. How do you sort through all of this quickly and accurately to give them the best advice? Well, that's exactly what this explainer is for. We're going to break down a clear, step-by-step framework to help you do just that.
So, before you even ask about their symptoms, your first move, and this is absolutely critical, is to figure out if this patient is in a high-risk group. This initial screen is your filter. It tells you right away how urgently you need to act and shapes your entire assessment. When you're thinking influenza, your clinical radar really needs to be pinging for patients with chronic conditions. Heart or lung disease, diabetes. Also, be on high alert for those at the extremes of age. So anyone over 65 or kids under 5, as well as pregnant individuals. These are the folks who are most vulnerable to serious complications from the flu. Now, for COVID-19, you'll see a lot of overlap. We're still watching older adults and people with chronic conditions. But, and this is important, notice the additions here. Someone who isn't fully immunized is at higher risk. The list also specifically calls out Down syndrome and gives a clear marker for obesity, a BMI over 40. And then we have RSV. With this one, your focus really narrows in on the very, very young, we're talking infants under 6 months old, and older adults, especially if they already have heart or lung problems. For these groups, RSV is so much more than a simple cold. It can be a really serious threat. Okay, so you've done your high-risk screen. Now you can move on to decoding the symptoms. This is where you get to put on your detective hat and start looking for those key clues that help tell these conditions apart. Let's start with fever, because honestly, this one symptom can tell you a ton. If a patient says they were hit with a sudden high-grade fever, like 38 to 40 degrees Celsius, that is a classic hallmark of influenza. On the flip side, with a common cold, a fever is pretty rare, and if it does show up, it's going to be very mild. Next up, the cough. The question to ask is, what does it feel like? Is it a dry, hacking, non-productive cough? That's what you'll often see with both the flu and COVID-19. But if it's more of a mild cough that eventually becomes productive, they start coughing stuff up, that's much more typical of a regular cold. Okay, let's talk about what's coming out of their nose. If they're describing this constant, clear, watery drainage, especially if they're also sneezing and have itchy eyes, your mind should immediately go to allergic rhinitis. But if that discharge is thick, colored, and just won't go away, that's a huge warning sign for a secondary bacterial infection. And here's a big one: body aches. I mean, the kind of severe all-over aches that make you feel like you've been hit by a truck. If a patient is complaining about that, true myalgia, that points very, very strongly towards influenza. With a common cold, those kinds of aches are pretty rare and usually just mild. So you've gathered all these individual pieces of the puzzle: fever, cough, aches, nasal symptoms. Now it's time to put them all together, synthesize that information, and start building a really confident clinical picture of what's going on with your patient. You can think of this chart as your quick glance guide right at the counter. See how influenza just jumps out with that combo of high fever and bad aches? And how the common cold really looks different with much milder symptoms that are focused more on the nose and throat. It's a great way to see it all laid out. But here's a curveball. What happens when the patient's story takes a weird turn? They tell you, I was actually starting to feel better, and then bam, I got so much worse. This is a critical moment in your assessment, and you need to pay close attention. This pattern has a name. It's often called double sickening, and it is a major, major red flag. When you hear this, it strongly suggests that the initial viral bug weakened their system, basically opening the door for a secondary bacterial infection to move in and take hold. And that brings us to our final and arguably most important responsibility: knowing the absolute, non-negotiable signs that mean a patient needs to see a doctor right away. Your judgment call here is crucial for keeping them safe. These are the red flags you cannot ignore: a fever that just won't break after 3 days, any trouble breathing or shortness of breath, a sudden severe sore throat, or that double sickening pattern we just talked about. If a patient mentions any of these, the only correct answer is an immediate referral. And when your patient is a child, you have to be extra vigilant. Look out for these very distinct conditions. A barking, seal-like cough, that screams croup. Trouble swallowing and drooling, think epiglottitis.
And an earache with a fever that pops up after a cold has already started. That's a classic sign of an ear infection. Any of these need a doctor fast. So you see, by following this kind of systematic approach, screening for risk, decoding the symptoms, and always watching for red flags, you're not just guessing. You're turning a vague list of complaints into a clear, actionable plan. This empowers your clinical judgment and, most importantly, keeps your patients safe. So, the next time a patient walks up to your counter with that cough and sniffle, remember this. This isn't just a bunch of information, it's a practical tool. Think about it. How will you use this framework to strengthen your very next consultation and help your patient get even better care?